He's not, he told me he was scared. He told me he scared the hell out of him. So they're gonna throw me up. Well, you don't know if I'm gonna do anything that's worth going in for.
You want to sit up here then too? Yeah. You should do that. Your reputation precedes you.
So it shows up as panel discussion. I think. Oh yeah, okay, there it is.
That's
Yeah,
you.
that's fine.
Okay. Good afternoon. I'd like to welcome everybody to our interdisciplinary session on pulmonary vascular disease and interstitial lung disease. We have a good program ahead of us, and we'll start this off with a nice pro-con debate. Dr. Stephen Matai from Johns Hopkins University will talk to us about interstitial lung disease and pulmonary hypertension and pro-therapy.
Thanks. Well, thanks, Mary Beth. Pleasure to be here today. I'm excited to debate my friend Patty. I think I drew the harder straw here, but hopefully by the end you'll be convinced of my position. I have some disclosures here which are listed. So I think whenever you're doing a debate, it's important to think about the art of war, as you all, I'm sure, have read The Art of War. But this quote, I think, is quite pertinent. Thus, what is of extreme importance in war is to attack the enemy's strategy. So, if I were Patty, and this is where she is about to regret the fact that she is Facebook friends with me, is that this is Patty. Patty is a very accomplished cyclist, by the way. Has biked more in an hour than I have in my life. But if I'm trying to put myself as Patty, what would I do to win this debate? Well, I would show this slide. This slide is you're not supposed to be able to really read the details of a slide, but this is a summary of all the clinical trials, case series that have been done in interstitial lung disease and pulmonary hypertension, and I'll cut to the chase, they all were negative. Here is one result from the Artemis PH study, which is an ambrisentan in pulmonary hypertension related to idiopathic pulmonary fibrosis, which was a negative study. The RISE IIP study, riociguat in PH-related interstitial lung disease, a negative study. I would even get a little sneaky and point out stuff that I've published, showing that there is no positive effect of pulmonary arterial hypertension therapy on scleroderma-associated pulmonary hypertension related to interstitial lung disease. And I'd probably end with this. There are no FDA-approved therapies for pulmonary hypertension related to any form of ILD. So at this point, I'm pretty much waving the white flag. And in fact, while Patty looks like this, I probably look like this. Okay, so what can be done? What can I do? What can I argue that would actually prove my point here? Well, I think we have a problem, and it's something called the right problem. We have not yet found the right patient or the right drug. And the question is, what do we know that can point us in the direction that we might be able to identify patients who would fit these criteria of a right drug and receive the right patient? So the questions that I would ask are, what is significant interstitial lung disease? We have a problem with our definition, I believe. What is significant pulmonary hypertension in the setting of interstitial lung disease? I believe this is also a definition that remains unclear. And another question that we have to ask is, does the likelihood of response vary by interstitial lung disease type? So is it IPF, hypersensitivity pneumonitis, scleroderma-associated interstitial lung disease, sarcoidosis? I'm not going to spend much time talking about sarcoidosis. Dr. Baughman's here. He's going to tell us about that. But I do think that there is some variability potentially in response to treating pulmonary hypertension based upon the underlying lung disease. And when we think about the right drug that one might choose, oral versus inhaled versus parenteral, there's something we have to keep in mind, and I'll show you some data that might suggest differences. Okay, so first thing is, what is significant interstitial lung disease? If we go to our clinical trials of pulmonary arterial hypertension therapy, the definition that is used to exclude patients with interstitial lung disease, quote unquote significant interstitial lung disease, is a total lung capacity or forced vital capacity of less than 70% or a DLCO less than 40%, along with moderate to severe fibrosis on high resolution CT scan of the chest. Well, if we look at the Fifth World Symposium guidelines on what defines interstitial lung disease-associated pulmonary hypertension, they use an FVC of less than 70% of predicted. And I have an asterisk there because that they specifically referred to this cut point only for patients who have IPF. This does not relate to scleroderma-associated interstitial lung disease or other forms of interstitial lung disease. So again, very narrow and may not be applicable to all of our patients. There might be specific definitions for certain forms of interstitial lung disease. There's a classification schema that has been was developed back in 2008 or reported initially in 2008, which is being used fairly frequently in the scleroderma population, where we define the extent of disease as either extensive or limited based upon the overall involvement of the chest on chest CT. So if it's less than 20, or excuse me, greater than 20% of lung involvement, and that can be any type of abnormality, that's considered extensive involvement versus less than 20%. So you can see here we have a problem with definitions. Well, what is that impact on our classification schema? And this is where I play a little dirty. I'm going to present unpublished data. But this is data we presented at ERS several years ago, where we looked at 50 or so patients with scleroderma-associated pulmonary hypertension with some interstitial lung disease. And we classified those patients using 3 different criteria. So the 3 criteria that I described, the clinical trial criteria, the limited versus extensive criteria, and then the FVC cutoff of 70%. And what is shown here is that patients who had, or group 1 here, I'm a lighter blue, okay, so by the clinical trial definition, most of our patients whom we ended up treating with pulmonary arterial hypertension therapies would fall into group 1 based upon the clinical trial definition. However, if we used either the limited versus extensive or the FVC criteria, you can see many of those patients that we had originally classified as group 1 PAH patients would be classified as group 3 patients. So what would that mean on the implications of assessing the outcomes to PAH therapy? If we have patients who we have included in our clinical trials of PAH therapy who actually would be considered by other criteria to have interstitial lung disease, what does that mean in terms of the impact of what we're seeing of these therapies on outcomes? Have we been including patients with interstitial lung disease in our clinical trials of PAH therapy? So the next question I ask is, well, what about significant pulmonary hypertension? This is from the World Symposium in 2013, the definitions now of pulmonary hypertension in the setting of interstitial lung disease or combined pulmonary fibrosis emphysema. That's what this abbreviation stands for here. So as you might expect, I mentioned the FVC cut point as being the definition, but a mean pulmonary pressure of less than 25 would be someone who doesn't have pulmonary hypertension. A mean pulmonary artery pressure of greater than or equal to 25 would be considered pulmonary hypertension. But this is the category that the committee felt was most important to focus on. Patients who had severe pulmonary hypertension, defined as a mean pressure greater than or equal to 35, or a mean pressure greater than or equal to 25 with a cardiac index of less than 2. So this is severe pulmonary hypertension. These patients, according to the guidelines, were recommended to be evaluated at tertiary care centers with the option to enroll in clinical trials and would be more urgent candidates for lung transplant evaluation. Well, does this make sense? Well, it might physiologically, and this is from a study that Isabel Blanco published several years ago, looking at patients who had underlying lung disease and the degree of hypoxic vasoconstriction that might occur in patients who receive the inhibition of hypoxic vasoconstriction that may occur in patients who receive pulmonary vasodilator therapy. So what's shown on this axis is the change in arterial oxygenation compared to the baseline PaO2. So as patients receive, and all these patients receive pulmonary vasodilators, I believe in this study it was sildenafil. And what they showed here is if you had a higher baseline PaO2, your change was greater than if you had a lower baseline PaO2, suggesting that in less severely altered vasculature, there's more active hypoxic vasoconstriction. These medications that we use to treat pulmonary hypertension inhibit the normal hypoxic vasoconstrictive response that occurs in the pulmonary vasculature. So this might be a sign. So what is the number of RCTs that have employed this definition of severe pulmonary hypertension, ILD, in clinical trials? None. So we have not studied this population to know whether or not these medications actually might work. There's one open label study done by Rajan and Rajiv Segar looking at patients who had various forms of severe interstitial lung disease who were referred for lung transplantation. And these patients, to get into this open label study, they had to have severe pulmonary hypertension. Now, this study occurred probably before the guidelines came out, and they didn't have a cardiac index criterion, but all these patients had a mean pulmonary pressure greater than or equal to 35 millimeters of mercury. And as you can see here, in a 15-week study of IV or sub-Q treprostinil, you saw significant improvements in pulmonary pressure, in cardiac output, cardiac index, et cetera. And going along with that, a significant improvement in 6-minute walk distance without a significant impact on saturation. These patients had improved quality of life as well. I'm not going to show that data. Okay? So they felt better, they walked farther, and their hemodynamics improved, which I think would be a win if we were able to do this for our patients who had interstitial lung disease-associated pulmonary hypertension. So the next point I brought up was the right drug. Which is the right drug? Does it matter whether we give an oral drug, an inhaled drug, a parenteral drug? Well, there might be some rationale. We've had 2 RCTs looking at the PH-ILD population, albeit not a severe pulmonary hypertension phenotype, ambrisentan and riociguat, both of which were negative studies or stopped early. There is a rationale for differing effects by PAH class, potentially. There is data showing that PDE5 inhibitors release normal hypoxic vasoconstriction, so they interfere with normal hypoxic vasoconstriction, probably as a class effect, not sure. ERAs may impact carbon dioxide sensing. The carotid bodies have ERA sensors, so it's possible that there's other effects, off-target effects from the ERAs that may contribute to their intolerability or ineffectiveness in patients who have interstitial lung disease-associated pulmonary hypertension. Is there a difference with the prostacyclins or inhaled therapy? Well, there might be, and this is all theoretical, but if we think about hypoxic vasoconstriction and pulmonary arterial hypertension therapy, in a normal alveolus with the pulmonary arterial blood flow here and pulmonary venous flow here, there's appropriate ventilation, there's no hypoxic vasoconstriction. If there is impaired areas of ventilation, there's going to be attendant hypoxic pulmonary vasoconstriction to reduce blood flow to that particular unit. Well, if this happens in pulmonary arterial hypertension, these therapies will release this hypoxic vasoconstriction and potentially send blood to areas of a lung that really aren't working well. So an ideal pulmonary hypertension therapy would be a therapy that would target ventilated lung, parts of the lungs that are working. So in theory, an inhaled therapy might be useful. And there are ongoing studies of pulmonary vasodilators that are inhaled in PH-ILD, including nitric oxide and inhaled treprostinil. So if I'm left to try to answer this question, should we treat pulmonary hypertension, interstitial lung disease with PAH therapies? I think we're still left with the question of identifying the right patient and identifying the right drug. But I'm going to ask Patty this question. If I had a 65-year-old woman with scleroderma interstitial lung disease on 4 liters of oxygen at rest, her FVC is 60% of predicted. She has 30% lung involvement by her CT. Her walk distance is 280 meters. Her saturation goes to 82% at the end of the walk. Her mean pulmonary pressure is 45. Her cardiac index is 1.8 liters per minute per meter squared, and her CT looks like this. She's already in pulmonary rehab. She's not a lung transplant candidate, because I know that's what you're going to ask me. So Patty, what would you do? And with that, I think I won. All right, thank you.
Well, I guess our next speaker needs no introduction, but I would like to introduce Dr. Patty George from National Jewish to talk about the con side of this debate.
Great, thank you. It was a great talk. So I've been given the formidable task of debating Dr. Matai, and am taking the position, or am given the position of con therapy, which, as I'm going to make the distinction, is really against vasodilator therapy in patients with PH and ILD. My disclosures include the fact that I have used and I continue to carefully consider the use of vasodilator therapy in patients with ILD and severe PH. So before I go any further, a quick definition. You might hear me throw out the words WHO Group 3 PH, and as most of you or all of you hopefully know, that's defined as precapillary pulmonary hypertension in the setting of chronic lung disease. So that can include emphysema, COPD, alveolar hypoventilation, chronic hypoxia, and of course in this talk, interstitial lung disease. And perhaps it's not hard to believe that I'm throwing up pictures from mountain bike rides, given you saw his slides. But I'm going to weave into this talk a few public service announcements from the great state of Colorado. So when you're on this ride, it's one of my favorite rides, not my top, you'll see that later, North Table Mountain. You're about to head out on the mountain bike trail, and right at the base of the trail, you see this sign. Rattlesnakes happen. So if you see a rattlesnake, make sure you give the snake time and space. And in the case of this debate and talking about PH-ILD, I think when we see it, we need to give the topic some time and space and really talk about what to do. So we all want to treat people. We're PH doctors. We want to make people feel better. And in PH-ILD, that has a horrible prognosis. Shown here is some data from the Giessen cohort. And if you look at survival curves comparing different diagnostic groups of pulmonary hypertension, this is PH due to lung disease, and it's much worse than IPAH or PAH. And if you break it out further, you can see that it's really driven by PH-ILD, extremely poor prognosis. You're talking about a 3-year survival of 40.3% compared to 72% in the PAH patients. In the UK cohort, it's equally dismal. You have PH lung disease, it's the very lowest survival curve here on the Kaplan-Meier. And again, if you break it out over here, PH due to ILD is really what's driving the extreme mortality difference. And again, 21% 3-year survival in PH-ILD, so it's a severe problem. But the question I pose to you, is it really the PH that's driving that mortality? Should we really be intervening on the PH side? So this is a survival curve taken from Zappella and colleagues, and this is looking at IPF patients. It has no regard for pulmonary hypertension. And then what they showed is that patients with stable disease, meaning their FVC stayed within 5% of their baseline FVC 6 months prior, that their median survival was 29 months. Of course, patients who had more progressive decline had worse survival curves, and you can see that there. So if I'm allowed to take the survival curve from the Giessen cohort and then just focus in on the ILD group, and we interlay these, you'll see that those are pretty similar survival curves. And so the question is it really the pulmonary hypertension or is it the ILD? And if we look at the guidelines, of course, one of the most quoted and noted parts of the European guidelines from 2015 is that, of course, recommending against the use of PAH vasodilator therapy in patients with group 3 lung disease. And why? Because this does not equal this, okay? So the pathophysiology of PAH, we believe, is due to environmental triggers, genetic predisposition, followed by pulmonary endothelial dysfunction, inappropriate and impaired immune and inflammatory responses, and pulmonary vascular remodeling. Versus on the other side, PH due to ILD, it's a different disease process. You're talking initially about hypoxic pulmonary vasoconstriction, then progressive parenchymal fibrosis, and you're crushing the pulmonary capillary bed, and finally, low operating lung volumes when patients get really restricted. You know, these findings are shown, again, this is similar to what Steve showed. All of the randomized controlled trials looking at vasodilator therapy in ILD have been negative and, in fact, dangerous in that we have black box warnings on ambrisentan, for example. If you look at the sildenafil data, again, none of the primary endpoints were met. Again, the Rio-Sigwat study was terminated early due to increased SAEs and mortality in the Rio-Sigwat arm. And even in a recent study looking at nintedanib plus sildenafil or versus placebo, again, no significant change in quality of life. So there's where the evidence sits, but there are other cons of vasodilator therapy that I think we need to consider. So, you know, these medications have side effects. You're talking about edema, headaches, perhaps increased GERD in patients who may suffer from GERD, jaw pain, worsening hypoxemia, as Steve so eloquently explained in his discussion. Being on a pump, having to mix medications, they certainly come at a cost of side effects that we routinely treat people through who have group 1 PAH because we believe there's a survival benefit. But there's also a literal cost beyond the side effects, and that's the price tag, of course. PAH medications are expensive. So in 2 recent studies that looked at cohorts of patients before the AMBITION study, meaning that at that point in time they were more likely to be on single agent therapy, it cost PAH patients over $3,000 or over $4,000 a month for these medications. That was the pharmacy cost. In a national survey in China of PAH patients and their caregivers, the financial burden was a 10 out of 10, which means extreme burden score, in 2/3 of the patients. And most often, the cost of those medicines would be 2/3 of their monthly income. So that results that due to this financial burden, over 50% of patients in China just aren't on PAH-specific therapies. Those are PAH patients. And we all know, those of us who take care of patients with PAH, these medicines are expensive. That's a drugs.com search, but they can be up to over $20,000 a month in cost. Now, very rarely do our patients pay that, but the stress of having to find patient assistance programs and getting patients medication every year is certainly not unnoticeable. All right, so this is a sign from Colfax in Denver. So if not vasodilator therapy, what then? You know, we've talked about it has a poor prognosis, that it's perhaps due to the ILD side, that there's a significant cost. But I would argue that it's not futile. It's not whether we treat our PH-ILD patients, but rather how we treat them. So my favorite trail in Denver is called Lair of the Bear. And if it's called Lair of the Bear, you shouldn't be surprised when you see a sign like this. And so when you do see a bear, just so you know, you should stay calm. And don't run, back away slowly, and if attacked, fight back. So the question is, how do we fight back in these patients with PH-ILD? So when I talk to my patients who have complex lung disease, I often talk about trying to optimize every single aspect of their care that we can and take this stair-step approach to hopefully elevate them to as high a level as possible in terms of their functioning and quality of life. So that includes things like lung transplant referral. So if somebody has pulmonary hypertension and IPF, that's an indication for listing for lung transplant. So you better have had that conversation or have it really soon, in my opinion. Secondly, you have to treat the underlying lung disease. So that may be antifibrotics or immunosuppressives, depending on what the nature is of their disease. Oxygen and sleep-disordered breathing, it's really important to optimize those. And for a long time, we relied on sort of common sense that treating hypoxia is important, but there was a really neat study that just came out in Lancet by Visca and colleagues, where they actually did this mini randomized crossover study, 2 weeks, on and off oxygen, in patients who desaturated with ambulation and had ILD. And they actually showed that they improved their 6-minute walk distance, being on oxygen, decreased their nadir saturation, and had improved quality of life. So we now have data justifying what we believe to be the case, that oxygen helps. And it's also important to think about how we optimize the oxygen. So do they need a high-flow nasal cannula? Do they need the pendant? Do they need a humidifier, transtracheal? So thinking about all those things with the patient. Pulmonary rehabilitation is certainly important, and in fact, there's data from Perez-Bogert, again from this year, where they looked at ILD patients who were in a pulmonary rehab program for 6 months, and they showed that they significantly improved their 6-minute walk distance, quality of life, and that was sustained at 1 year. So it helps even in ILD. Treating GERD, you could talk for hours on GERD and interstitial lung disease, but certainly if patients are symptomatic or if we believe that it may be promoting worsening fibrosis and or it's triggering their cough, we certainly should treat it. Nutrition is important for us to address, and we see people on both ends of the spectrum. You have patients with metabolic syndrome, morbid obesity, that have difficulty breathing, and patients with pulmonary cachexia, which is really ominous. In a study by Nakatsuka and colleagues looking at cohorts from the UK and from Japan, they showed that body mass was associated with worse survival in ILD. And finally, symptom-based management, that's super important. When I think about that, I think about treating their anxiety, treating the things around their disease, perhaps palliative care. And there's a study in 2015 by Segala and colleagues that was looking at the feasibility and safety of using mindfulness education in patients with ILD, and they did an 8-week trial and showed that at the end of that 8 weeks, first off, it was safe, they didn't have any adverse outcomes, but that the patients felt better, their stress scores were lower, their dyspnea scores improved. And there's even more intriguing literature in the cardiac disease. So, but what about the real-world experience using vasodilator therapy in PH-ILD? And Steve already pointed out the study by the Sagars, which was that open-label trial looking at sub-Q and one who was on IV treprostinil. There's also the Compara registry that looked at PH patients on vasodilator therapy, and they looked back and were comparing patients with PH-ILD versus PAH. And of course, the PH-ILD patient survival was worse, but one intriguing graph from that study is up here, which showed an improvement in survival in PH-ILD in those who responded to vasodilator therapy versus non-responders. And then there's also the retrospective study by Lang and colleagues that showed a survival benefit in PH-ILD patients who were treated with vasodilator therapy. The caveat to all of these being that all of these had severe PAH, or it was driven by severe PAH. And so we have to acknowledge that and kind of talk about, again, I think we come to agreement on really deciding the what of the disease. And I would argue that in those studies, perhaps it wasn't their PH-ILD, but rather a PAH that was driving it. And so looking at the World Symposium and putting those two graphs together, two charts together from Steve's talk, it's really looking at the severity of lung disease on the x-axis, so to speak, and then their pulmonary hypertension. And when you look at people who have no or minimal ILD, and you look at patients who have severe pulmonary hypertension by the definitions that Steve defined, we don't really know if these people truly are PH-ILD group 3 or are they truly a PAH group 1 phenotype. And that's where we really need to spend more time in research. So in summary, my main arguments against treating patients with PH-ILD with vasodilator therapy is that the guidelines recommend against it. There's a lack of randomized controlled trial evidence that it improves mortality. It's really the interstitial lung disease and not the pH driving their mortality. And there is a cost to these medications when we try to use them off-label. So focusing on vasodilator therapy may in fact be stealing our attention and our focus from other avenues that could be of true benefit, like lung transplantation, pulmonary rehab, other comorbidities, and symptom management. And with that, I'll leave you with my final public service announcement from Denver. And I thank you for your attention.
Now I'd like to introduce Dr. Boffman, who will speak to us about pulmonary hypertension in a very specific disease, sarcoidosis, that might be a little bit different than what we've just talked about.
Thank you, Mary Beth, and thank you for the opportunity to talk to this group. I think the last two talks really were a nice lead into what I was going to talk about, which is specific disease sarcoidosis, which I hope to convince you is actually a little bit different than what you've been hearing about with other interstitial lung diseases. I also point out that there still is no FDA-approved drug for sarcoidosis. I'll start off with this slide pointing out that there are a couple things that are in common with other ILDs. There's constrictive disease because of loss of lung parenchyma, and there's hypoxia, but there are other reasons why patients with sarcoidosis get pulmonary hypertension. they get vascular disease, they get actually granulomas growing into the vessels. And so when you look at a patient with sarcoidosis who has pulmonary hypertension, it's not just one reason. And some of those reasons may actually respond to therapy. Now, the incidence of sarcoid-associated pulmonary hypertension depends a little bit on how you look. On this slide, if you just look on the left, the patients who go to sarcoid clinics across the world, somewhere between 5 to 15% of those patients will have pulmonary hypertension. However, if you go a step up to those patients who are on therapy and are still persistently dyspneic, haven't responded to anti-inflammatory therapies, you get up to about 50%. And if you go further, the ones that are getting listed for transplant, you're about 70 to 80%. Now, these numbers are higher in general than what you see with idiopathic pulmonary fibrosis. And there is a difference in the outcome based on what type of pulmonary hypertension you're dealing with. This is a study we did at our place, 130 patients in a row doing right heart cath in patients with persistent dyspnea. More than half of them had pulmonary hypertension, but a significant number had it on the basis of left ventricular dysfunction, whether direct cardiac involvement from their sarcoid or other reasons. But if you look at the mortality, it was only those patients with precapillary pulmonary hypertension, labeled here by SAF, are the patients who had the reduced mortality, which is not much different than the last couple Kaplan-Meier curves that you've seen, whereas those with left ventricular dysfunction do relatively well compared to those with the normal cath. So again, it depends a little bit on what type of pulmonary hypertension you're dealing with. So the rest of the talk, I'm going to talk about precapillary pulmonary hypertension. So this is a registry that we recently published on. It's a multinational registry. And at the end of the day, we had about 170 patients with sarcoid-associated precapillary pulmonary hypertension. And this is the PA mean measurement. And it's trying to use the arrow, probably won't be able to get it to work. But if you look at this, there's actually a shoulder here. If you use 35 and greater, which has been pointed out as what we consider severe, you see a bump. You don't really see that with idiopathic pulmonary fibrosis. You see the tendencies to drop off over time. So there's a second group. And these patients, I would argue, are maybe the vasculitis type. So there is a group of patients with more severe pulmonary hypertension than you necessarily see, and this may be a target of therapy. Nevertheless, patients with sarcoid pulmonary hypertension, in general, tend to have more likely to have fibrotic disease. And in sarcoid, we refer to this as scatting stage 4, that is fibrosis. Scatting 1, 2, and 3 are lymph nodes and infiltrates. And you see that about half the patients with pulmonary fibrosis, pulmonary hypertension have pulmonary fibrosis, but that means around 40 to 50% of the time, you'll have no evidence for pulmonary fibrosis on imaging. If you look at the vital capacity, in general, those patients with sarcoid-associated pulmonary hypertension tend to be lower, but in fact, there is no correlation between vital capacity and the level of pulmonary hypertension. This is from our registry that we had. On the other hand, DLCO tends to be lower, and there is a correlation here. The lower the DLCO, the higher the pressure, but many in the room would say that that's really pushing it to say that that's a correlation. So again, the fibrosis doesn't necessarily drive the pulmonary hypertension in patients with sarcoidosis. So we do see desaturation, and I think this is important, and I'll talk a little bit about this as we go along. And it's important to realize as a screening tool, most patients with sarcoid-associated pulmonary hypertension desaturate during their 6-minute walk. And that's a combination of factors, not only the interstitial lung disease, but also the pulmonary hypertension. So what happens to these patients? Unfortunately, they do die. They don't die as rapidly as they do in IPF. This is the French registry, which is approximately 170 patients from just France alone. It was also published recently. It was published at the end of last year. And you can see that the mortality at 2 years is somewhere around 20%. Our study that we presented at the ATS, the mortality for our group, is a similar sort of factor. So there are patients who die, and these patients, we wonder whether there's a target for therapy. So this is, if you look at a group of patients at our institution, this is about 450 patients overall that we had 10-year or longer follow-up, you can say the presence of pulmonary hypertension was by itself an independent predictor of mortality. Independent of fibrosis, pulmonary hypertension, reduced vital capacity. So pH by itself is an independent predictor of mortality in patients with sarcoidosis. So what about therapy? So there are several trials that have been done. Some of them are open label, some of them are prospective, and there are at least one double-blind placebo-controlled trial. And I'm just going to go for the sake of time just to show that various different agents have been looked at. I think it was nicely pointed out that we still haven't discovered which agent is the best, but at least in sarcoidosis we have several, and they have some improvements in some of these trials. For example, epoprostenol and inhaled iloprost have had some clinical improvement. If we look at the endothelin receptor antagonists, there is one double-blind placebo-controlled trial that shows some improvement, and with ambrisentan, there is some but mixed improvement results in an open-label trial. This is the bosentan trial, which was a study of 43 patients treated with either bosentan or placebo over the course of 16 weeks. And it was a 2-to-1 randomization for those of you that are trying to calculate the numbers, why they work out that way. And we did follow-up right heart catheterizations. And so if you look at what happened to these patients after therapy, there was a significant fall in the mean PA pressure after 16 weeks of therapy, which was not seen in the patients with placebo. And interestingly enough, though there was desaturation that was starting to occur, and about 20% of patients on the bosentan developed desaturation, more desaturation during the 16 weeks of therapy, we saw a similar rate occurring in the patients on placebo. So desaturation is a fact of life in patients with pulmonary hypertension and will potentially get worse over time. However, what we did not find was any change in the 6-minute walk. So after 16 weeks of therapy with a successful change in PA pressure, we did not show any change in the 6-minute walk distance. So as you're used to in WHO Group 1 patients, seeing a change in PA pressure corresponds to a change in 6-minute walk, we did not see this in interstitial lung disease. What about other drugs? Well, the phosphodiesterase inhibitors have been mostly looked at with looking at 6-minute walk, but there was one trial that looked at improvement in cardiac hemodynamics, but did not show any change with 6-minute walk distance. And then multiple drug therapy, what you in fact do in your PH clinic for patients nowadays. This has not been prospectively looked at, but it has been retrospectively, several series have been published using this. So getting back to the French registry, which is a large number of patients, nearly 100 patients on PAH-targeted therapy, they looked at what happened to their patients. And right here, I'd like to insert the comparison of the French registry to the to the US and European registry is a little bit different. If you look at the French registry, almost everybody got treated with PAH-specific therapy. If you look at the Europeans in Saudi Arabia, almost all of their patients got treated, but in the US, a third of our patients did not get treated. And this was not actually associated with severity of disease. So for reasons that we're still trying to tease out, we didn't actually use this therapy as much in the US as we do elsewhere for sarcoid-associated pulmonary hypertension. In the French registry, they showed significant improvements in hemodynamics after a period of time in the first follow-up visit, which is usually around 4 to 6 months after the visit. However, what they failed to show was any change in the 6-minute walk distance. So there are other studies that have shown that. This is a retrospective study looking at 2 places, Johns Hopkins and Steve Nathan's group at Inova, looking at real-life therapy, often patients getting on combination of therapy, and what they showed again was a significant improvement in hemodynamics, somewhere around 6 months of therapy, but they also showed improvement in 6-minute walk. But when they did the analysis of this, they just took the median value of their sarcoid patients who were treated, and that was 51%. So half the patients had a vital capacity of greater than 51%. And it was only those patients who had a higher vital capacity who had a significant improvement in their 6-minute walk of over 100 meters, and there was no difference in those who were treated below. The duration of follow-up before they did their first 6-minute walk, though, was around 9 months to a year. So it wasn't just at 16 weeks. It was a longer period of time when patients were treated. So this kind of brings up this tipping point, that when people ask about therapy for sarcoid-associated pulmonary hypertension, you have to think about the underlying parenchymal lung disease. So if you look at the left, your left here, if you have a vital capacity of 70% and you can't walk very far, it probably is driven by the pulmonary hypertension, not so much the fibrosis. On the other hand, if your vital capacity is 30%, it's probably more driven by the fibrosis than it is the pulmonary hypertension. And where that number lies, it's probably between 50 to 60%, based on a couple studies, the biggest of which was the Barnett one. So this is how I think about treatment. This is kind of our algorithm based on what we have. If you take patients with sarcoid pulmonary hypertension, you treat them with oxygen. you look for the underlying inflammatory patient. So occasionally a patient will respond to just corticosteroids and other treatments. Some of these patients will respond to stenting. And then you go down the pathway of trying different agents. And a patient who has a low vital capacity, non-response to therapy, that's the patient that we think of consideration for lung transplant. Do we change the outcome of these patients? Although we can show improvement in the pulmonary artery pressure, we're not so sure that we can improve their functional status, and we're not sure that we change their quality of life, and there's really no data yet on the long-term clinical outcome. And so that's one of the things that we're trying to get better handle on. So I want to thank the people that I work with in Cincinnati, and mention the ISOG group, and ask you all that if you do see patients with sarcoidosis, encourage you to join the WASOG Sarcoid Clinic group. Thank you very much.
Thank you, Dr. Boffman. And we want to conclude our conversation this afternoon looking at our pulmonary hypertension in the autoimmune population, and Dr. Hap Farber from Tufts Medical Center will bring us through that. Thank you.
I'm wearing a jacket.
It's cold in here, what can I tell you? So I was chosen to do this like Sunday, okay? And we're not talking Sunday a week, okay? So they didn't tell me what to talk about, so I'm just gonna sort of wing this to what I thought we'll talk about. So those are my disclosures. And what I was gonna talk about are a couple of things. One, the usual causes of ILD and autoimmune disease, okay? And PAH or PH, really connective tissue disease, current treatment for that. And then this sort of new thing that I would guess most people in this room don't know a lot about. I certainly didn't before Sunday. Interstitial pneumonia with autoimmune factors, or IPAF. You gotta love it. It's got a great little abbreviation. And then is this thing called IPAF associated with PH or PAH? And how do you, if it is, how do you treat it? So when we think of normal autoimmune disease and ILD, we think of basically connective tissue diseases. And the normal connective tissue diseases are the ones you think of, scleroderma, lupus, et cetera. Okay, so that you run into the same questions every time, and most of these have actually been sort of touched upon by the people who spoke before me. So one is, are these people really group 1 PAH, or are they group 3 PH? And the issue is, well, they could be either, or they could be both. Or to be honest with you, I don't have a clue, okay? And anybody else up here who says they do doesn't either, okay? We honestly do not know when we're looking at these people whether they are group 1 or group 3. And that's part of the problem with all this. We really, in all honesty, have no idea what we're treating, okay? So they could be group 1, they could be group 3, okay? But as was sort of alluded to by everybody here, we sort of go after this by how much ILD do you really have, either by your CT or your PFTs, and how bad is your pulmonary hypertension. Okay, so most of us, and Patty and Steve aside, I guarantee you when they're sitting there in clinic, they're looking at the same things and thinking, okay, this person doesn't really have a lot of interstitial lung disease, but their pulmonary pressures are terrible, but I don't know, but I'm going to treat them. Okay, if I took it the reverse, they go, gee, I don't think I should treat them, but God, they look terrible. I'm going to treat them anyway and see if they do okay. Okay, that's the real world, right? Yes. Okay.
I'm on the pro side. You have to talk to her.
No. I mean, because you can't tell, okay, and because you have somebody who's really sick, you tend to err on the side of I'm going to try and do something without thinking about, well, I might do something horrible, but that's the way we are, okay? So then the question is, realistically, if you think about it, we've never in any of the clinical trials eliminated interstitial lung disease from the people we treat. Granted, to get into trials for PAH, you have to have an FVC of greater than 70%, but you don't have an interstitial lung disease component of 0. Okay? So almost every clinical trial we've looked at so far has people with interstitial lung disease in it, whether you like it or not. There are, and actually nowadays with the CT technology that's available, I defy you to find somebody with scleroderma who has no interstitial lung disease. It's incredibly uncommon. So we're already treating people with scleroderma or connective tissue disease with interstitial lung disease, and we've done it, if you want to say, legally versus illegally, okay? So how this all works out, I don't know. But we do know one thing, okay? And based on recent studies, we do now know, probably, that these people, at least the people that we've included in clinical trials with whatever degree of interstitial lung disease they've got, do better if we get more aggressive with their treatment, okay? Up until, recently, people with connective tissue disease, especially scleroderma, okay, did lousy with PAH treatment. There was no way around it. But and I just picked a couple of examples. More recent studies, the first one up here is the connective tissue cohort from the Ambition study. Actually, if they're aggressively treated, the top part is lupus, the bottom part is scleroderma. The top is scleroderma, the bottom's lupus. Basically shows that you can pretty much, with combination therapy of tadalafil and ambrisentan, achieve the same risk reduction you could in the whole PAH cohort. Okay, so that's good. Okay, and then if you look at Griffin, which basically adding selexipag to background therapy, and this is the scleroderma cohort pulled out, and on the left you have scleroderma, and on the right you have lupus, and once again, by getting aggressive with therapy, you have pretty much equated what the whole cohort showed. Now, obviously, even though we don't know for sure how much interstitial lung disease these people had, we know they had less than, their FVC were greater than 70%, or they couldn't have gotten into the trial. Now, do we know that any of this carries over to the real world population, i.e. the people who couldn't or wouldn't have qualified for the trials? We have no idea, okay? But being who we are, we automatically extrapolate that it must work, okay? Whether we know it or not. And we're not gonna know it for a long time. We may never know it, okay? So that's sort of where we are. We don't know what we're treating, but we tend to treat people more if we think that their interstitial lung disease is a minor component. But we do know that if you've got an FVC of greater than 70% and you get aggressively treated with combination therapy, you're likely to do better. That's where we know with connective tissue disease that we consider, quote, normal. So what about this other thing? Okay, well, this other thing is either new or not so new, depending on how you want to look at it. Actually, if you go back and you look, it's been around for a while. It just now has a name. So it's not that it all of a sudden popped up in 2015. It's been out there. So this is IPAF, or interstitial pneumonia with autoimmune features. And I would bet to say that most people in this room who take care of a lot of connective tissue people have seen this. And as I was thinking about this, yeah, we've always run into these people that have a little interstitial lung disease. They look like they have a connective tissue disease, but I can't prove it because they don't fit the mold. So they probably fit this mold. So in 2015, the ERS and the ATS got together and made a definition for this thing. So, and this is the definition. You have to have interstitial pneumonia. You have to exclude any other alternate etiology you can think of. And you have to meet what is called no specific criteria for a defined connective tissue disease. So it's basically an undefined connective tissue disease. So you got some features that look like a connective tissue disease, but you don't fit the American Society of Rheumatology's definitions. And this part is, you have to have at least one feature from at least two of the following domains. So you have a clinical domain, a serologic domain, and a morphologic domain. And I'll show you what those are. So the clinical domain is mainly your fingers, your hands. So you have to have something wrong with your digits, pretty much, okay? Fissuring, ulcerations. You're looking close, Patty. You got any of it? Okay, telangiectasias, Raynaud's, etc. Or some inflammatory arthritis. Okay, so all you need is one of these things. Probably everybody in this room has one of these things. We're going to go around and check at the end. No, I'm kidding. And then your serologies are incredibly encompassing, really. So you have to have an ANA of greater than 1 to 320 in a diffuse speckled or homogeneous pattern, or any ANA titer if it's nuclear or centromeric, or a rheumatoid factor of 2 times the upper limit of normal, or positive CCP, or in any one of the other following ones, which pretty much encompasses almost any serologic test you could do for any of the connective tissue diseases. Then you have a morphologic domain, which on a CT you either have an NSIP pattern, or an organizing pneumonia pattern, or some combination of the two, or an LIP pattern. If you happen to have histology in these people, it has pretty much the same thing as the CT pattern, except you can have interstitial lymphoid aggregates with germinal centers and diffuse lymphoplasmacytic infiltration. Say that fast 3 times. The last one, which I thought was pretty interesting, is you have this multi-compartment involvement associated with interstitial pneumonia and either unexplained pleural or pericardial effusions, or unexplained intrinsic airways disease, or unexplained pulmonary vasculopathy. And these are the people that get sent to us, okay? So then the obvious next question is, what's the incidence of this unexplained or explained path pulmonary vasculopathy in people who have IPAF? And the answer is very simple. We have no idea. I actually looked again this morning. There are 0 reported cases in the literature. 0. Okay, there is no clinical report of any cases. Now, I personally was thinking about this, and I know I've seen some of these. Okay, we clearly have seen some of them, but it's just nobody's actually written them up and reported them yet, which is bad because they do need to be defined and characterized if we're going to figure out who they are and what to do with them. So obviously from that, the next question is, how do you treat them? We have no idea, okay, because since we have no definition, we have no systematic study, so we don't know how to treat them. Now, currently, I would assume, and I think thinking about the people I've seen with this, as to what we've done, we pretty much have just treated them as any connective tissue disease. We've not differentiated them in any way, shape, or form. Now, whether that's right or wrong, and whether they do as well or not as well, to be honest with you, I don't know. My impression is that they seem to have roughly the same response as people with underlying connective tissue disease, but I don't know, and I probably have a very biased, very small population. So, ultimately, this is an entity that clearly is out there and is now defined, and obviously needs to be studied, and obviously needs to be characterized, and then some sort of clinical trial, once you have a characterization of these people, to see if they do respond like or not like our current therapies for connective tissue disease. And as far as the normal connective tissue disease, basically, I think we're treating people that Patty talked about that we shouldn't treat. We're treating people that Steve talked about that we probably should be treating. But the bottom line is we have no idea who we're treating, okay? But we're treating a lot of them. I mean, I can tell you that from my own clinical experience. And that's where I'm going to leave you. So thank you very much.
Okay. We do have time for questions. I can invite the panel to come up to be able to answer them. We're one
That's okay, I can stand.
seat short.
I'll stand.
Just fine. You can stand there. Please go ahead. Thank you.
Hi, great session. Dr. Boffman, I noticed in your recommendation slide about the treatment choices, you gave some graded recommendations for the different agents. Did I recall that you had a higher grade for IV propranolol compared to the orals? Did I read that correctly, or?
Yeah, the recommendations were based on the old grade system that was set up by Guyton for the ACCP and based on clinical trial and there were a couple open label trials for some of the drugs. The IV propranolol was actually based on the Chicago data, for example. The only one that should have been a grade A recommendation was the bosentan trial.
No, I thought you had the IV propranolol was higher than bosentan or sildenafil.
No, that was the case. It was a typo.
Okay,
So.
all right.
question for the group while we wait for shy people to come forward. So really controversial, great coverage of the material. What do you think as a group are the next steps we should do? Do we need to get a registry and organize these folks? Do we need to go after the severe that seem to where the data looks the most promising? Should sarcoid be included in this group or should it be always kept separate? What are your opinions on next steps to really elucidate some of these questions?
Ladies first.
Yeah, so, let's see. All right. So, I think, the one thing that we've definitely highlighted today is the need for more research and what direction does that take. I do think that registries would be an excellent idea, and we've seen certainly some of those studies when you look at the Compara study and the UK cohorts. It's good to have and start recording and understanding these people in the form of a registry. I think it also comes to perhaps employing better techniques at phenotyping patients. So one of the conundrums that I think we come up with when we treat these patients who may have borderline precapillary disease is it really, or on their right heart cath. So for example, maybe they have a mean pulmonary artery pressure of 28, but their wedge is 14, but he's a 70-year-old smoker with hypertension and happens to have ILD. Is that really precapillary disease? And you may not know that if you don't do provocative testing like exercise, right heart cath with exercise, or fluid bolus and fluid challenge. So I think trying to really discern the phenotypes of these disease on an individual basis is important. That'd be hard to do in a registry, of course, because not everyone uses those techniques. So yeah, I think that would be beneficial. And then should we focus on severe versus mild? That would seem to make sense because if you look at data that looks at ILD-PH or pH related to ILD, the most severe patients are those. There was one study that broke out people with a PVR of greater than 6 or 6.23 had worse survival. So that points to the fact that these people really have a pulmonary vascular disease, and that certainly would seem to be the ones you'd want to target with any sort of vasodilator therapy. And of course, the most recent RISE IIP trial didn't target those patients. It was just baseline precapillary disease in their definition. So we probably asked the wrong question before that trial started.
And I would argue that perhaps if we're going to think about a big picture routine catheterization of patients who have this as a part of the evaluation for dyspnea, unexplained dyspnea would be a nice start. But I also think focusing down on a population that we know has concomitant pulmonary vascular disease as a phenotype of their disease, i.e. the scleroderma population, to me makes the most sense to study. You have a scleroderma interstitial lung disease patient, the likelihood of that patient having true pulmonary vascular disease is probably higher than the same IPF patient or hypersensitivity pneumonitis patient. I don't know if I can say the same for sarcoidosis. But I think that population in particular is a unique opportunity for us to study the impact of these therapies on outcomes. Fairly heavy.
I'll lean. It's hard. I mean, you have to agree with both of those. I think the thing we have to keep in mind, though, is that before we get carried away here with treating everybody's pulmonary hypertension, is the fact that we have to prove a couple of things. One, we do have to prove that, that their actually demise is due to their pulmonary hypertension and not their interstitial lung disease. Two, we have to prove that even if they have pulmonary vascular disease and we treat it, we alter their outcome. Because their outcome, even though we can change their hemodynamics, their outcome may be actually driven by their interstitial lung disease and have nothing to do with their pulmonary hypertension anyway. And I can look good because I can make their numbers look better, and the patient looks at me and goes, I don't feel any better, okay? So I think that's probably most important. And then what you're looking for among all of those are this group, if there is a group, this subgroup or this niche group of people who actually, by treating their pulmonary hypertension, you do actually improve not only their short-term outcomes, i.e. their quality of life, whatever, but their long-term outcomes, okay? So that, to me, is the thing that's the most important, and unfortunately, that's probably the hardest thing to do.
Yeah, I would just echo that because I think that if we look at what we have, there is a subgroup of patients that we've already shown, scleroderma, and sarcoid are diseases in which we can control the interstitial lung disease to the most part. There's a subset we can't. But those are the people we focus on. And I think we're actually starting to see in IPF a subgroup that we can actually control and should actually identify before we start treating the PH. The nintedanib and sildenafil trial is an example, but they did not go the first step, which is to show that the patients were already responding to sildenafil and then already responding to nintedanib and then add sildenafil. And I think as time goes on, those studies are going to start to come up. And then I think you really identify the patients that you may benefit their therapy.
Dr. Baughman, I have a quick question. Do you think the sarcoid patients should be considered separately in clinical trials and in clinical evaluation?
I think they should be handled like we handle scleroderma, which is that you have a group of patients that are more likely that the interstitial lung disease. I've always had this problem with IPF, which is that, as I've said, these patients are going to die from their fibrosis regardless of what you do with their pH. And we're just starting to slow that down, not necessarily stopping them from dying.
So I think all great points by Patty and Hap regarding the high mortality rate in people with IPF and PH. And despite the slides that you showed that it's the decline in lung function, but I think there's enough data that for any given degree of lung fibrosis, when you have pulmonary hypertension, the outcomes are clearly worse. And this is a group that has a very high mortality rate in a very short period of time. So I think that's an ideal population to study mortality as the endpoint. Because even in Raj Sagar's study, he showed that the walk distance improved, the hemodynamics improved, the echocardiographic parameters improved, but you don't know, the patient could have still died. They may die quicker because you've maybe flogged the right ventricle and precipitated right heart failure later. So I think it would be, you could get enough patients for that study given the high number of outcomes.
Great talks. Steve, I have to apologize, but I missed your talk, and you may have touched on this in it, but the question has to do with the inhalation approach, and of course we have the INCREASE trial for Tyvaso, but there is data dating back 20 years on iloprost showing improvements in gas exchange and so forth. So it looks like maybe there's a role for prostacyclins. Sildenafil can be given by inhalation. There are a lot of potential small molecule molecular therapies that could be administered as well. So question number one is, what's your experience, and what kind of approach do you think might work best for patients with interstitial lung disease in response to the inhalation route?
Yeah, thanks, Nick. You really didn't miss much. It was pictures of Patty biking and me surfing. But I did touch a bit on the inhaled route and why that is attractive from a theoretical standpoint, particularly when we think about VQ matching and potentially the improvements that that route of delivery might do. I think that personally, I have some experience with that particular route of delivery, and I think in some patients it works. The major side effect, as you know, is cough. And for these patients who have underlying lung issues, the cough can be problematic given their lung disease predisposes them to cough. So I think that's one of the downsides. But I think in general that route of delivery of medication for the right patient, someone who's got kind of severe pulmonary hypertension in the setting of some interstitial lung disease, makes sense.
Yeah, the STEP-IPF study actually showed some promising results, and you wonder whether some kind of PDE5 inhibitor might be worth looking at as well.
And the INO study's going on as well.
Right.
Yeah.
Thanks.
Thank you, everyone. Thank you very much. That was great. That was a good discussion.
Were you the person who put this in, or thanks for asking me?
Well, I think sarcoid's a really important category. I think it doesn't really fit in the box, right? So, yeah. Hey. Oh, yes. Pulmonary junction. Nice. Yeah. Wow. How many pulmonologists are there? Gosh. it for you, so hopefully it's a one-stop shop for you, and then your office can handle it. And you should just take my cell phone, like when you have questions. I'm happy to, I told Mike, I said, sometimes it's just a matter of a question, the patient doesn't want to come. And I used to work in Alamosa, so I'm familiar, Alamosa is in Colorado, yeah. And just as a general insurance, before I did my commission, but I know that feeling, they get out there, and the patients don't want to go, and you don't know what to do. Yeah. And then it's all that, then it's a disaster of all that data transfer, your stuff to them, their stuff to you. It's just cool. But anyway, yeah. So, my phone number is 801-657-2370. Yeah, exactly. Yeah.
And really, the same may come up, probably less frequent if we have patients. So we're doing a bunch of clinical trials with hospitals.
Oh, you are? Okay.
So if there's stuff that we need done for patients who are on our side. Oh, that would be good.
Oh, you did? Okay. Yeah, oh, good. Well, that's nice.
Yeah.
So as a Grand Junction patient that was there, I see one person. Yeah. I feel like I see one that maybe popped in to see you or maybe was gonna see you. Anyway, I feel they're not from Grand Junction, but that's where they get their health care, but they're from like Utah. Yeah, yeah. Yeah. Oh, right. So but it was between Moab. I can't remember. It was a small town. But yeah. Oh, that's huge catchment area. Yeah. Yeah. We'd be helping them out anywhere we can, and we should come do some outreach or that kind of stuff. It'd be great. Yeah. So it's a big population area, and it's growing.
That referral area in the county itself is somewhere like 150,000 people. And then I have patients driving 3 hours to see me. So you can imagine when I talk about it, I'm driving 4 hours to go to the city.
Yeah. No. Exactly. So we can.
I have some patients that are insurance dependent, which structurally.
Yeah. So you should definitely be her. Yeah. Fabulous talk. She's great. So yeah. So well, good to meet you. Yeah. He told me. Oh, it's good. I was. Yeah. Yeah.
I was
Years ago now. Yeah. All in Oregon. Yeah.
and I did fellowship under Sarcoidosis in Richmond, Virginia.
Okay. You've been all over. How'd you settle on Grand Junction?
I wanted to go back to Oregon. I wanted a smaller community, and I did a MHA during fellowship, interested in quality and health administration. So I wanted the system.
To that kind of job.
So I took the grant.
So you're trying to move into our administration a little more. I know. That's what I do. I do a ton of that at the U. I try. You know what we should try to do? We should, because I'm really interested in that in the U, and my latest focus has really been on some of this outreach and referral relations and stuff like that. Just marketing ourselves. So we should think about. We should try to create a novel. I don't know what it is. I'm just thinking of like some great way that we cooperated, and that we could talk about systems that we should try it out and see where we can make the systems better, and then talk about you're not really rural, but I guess referral to you're kind of, or I guess you call it rural, but I wouldn't be a rural health, but it would be some kind of enhancing referral communication or relations or something. I don't know what. I mean, maybe it's not. Maybe it's all there, but like telehealth or that's all there. I mean, we should.
Here's a full patient file and all the information that I have. Here's everything. And then have somebody, a committee or people from your institution, in that case, give us recommendations on that person.
It'd be great if we go for it. Yeah. Yeah, I am too, but I mean, it's a good idea. I mean, it'd be a good idea to sort of, it's just it's a universal problem, right?
I have a case there, I gotta figure out which one.
Yeah, what's in the spine? You should find Bob. He'll tell you half the time you don't have to treat it. So half the time, it's just fascinating, but you don't treat it anyway. So it's too bad you missed Bob. He would love to talk about that. Yeah. Yeah, if he's out in the hall, you should grab him. Yeah. So, yeah.
Hi, Victor Marchetti.
I'm Matt. Yeah, nice to see you.
Nice to see you. And Max.
Nice to meet you. So it was weird. It's not really, the way they set up wasn't much of a pro con. So I sort of like briefly go over some of the physiology and set up the trial so you can
Okay.
Yeah.
It's not that strong though.
But that's okay. I mean, I think it's just to generate, to present research.
So you also going to talk about esophageal manometry.
Yeah, so just briefly, sort of like the basis of it, and then yeah.
Probably for my talk I will try to go faster.
Yeah, you'll see. And then if there's anything that is glazed over, I don't want to use the self-check ones we have.
Yeah, we do, but usually when they are very hypoxic.
We don't use
Just-
it very much. I should say, rephrase that. We don't ever use it outside of research.
But it's not common.
No. Yeah, that's how you touch upon that.
Most of the times, the patient doesn't respond to paralytics with wrong.
That's yeah, we've done that too. I don't know how good that is, but that's what we do. So it's set up, I guess.
Usually, if patient morbidly obese,
Yeah, it was like just
with
water
an
maladies.
infusion, you're not sure, maybe it's
Yeah.
not that bad.
So I can show you my slides. I mean, I just kind of try to go through the pathophysiology, but not the inflammatory portion of it. Some basic physiology, like from the 70s. Lung compliance related to the baby lung. And then dead space, talk about this. And then this is about all I have on esophageal pressure, sort of like the idea of why you'd want to put it in. Basic formulas, a representative graph from the review article. And then I talk about this trial. And then the most interesting part, to me at least, is, well, they go through some of the examples from the cases in there. Is this new paper, Toshida?
Yes,
Yeah.
Yoshida.
Yoshida, not Toyota. Toyota is our surgeon. Yoshida, yeah. So this, I think, actually changed things in the next 3 to 5 years. So this was my argument that, hey, nothing's been done for 10 years, right, since that 2008 article. Yeah, but I think it's going to change because now you know which measurements to use. But, I don't think we'll get a result.
I think we're going to talk about this in a different perspective.
That's fine. Yeah, which is fine. But we just. Okay. Welcome to the session. There's a series of announcements. My name's Nat Marchetti, and I am working with Dr. Kazu from Michigan State. This is supposed to be a pro-con debate. Ironically, this weekend, Penn State, which is where I went to school, and Michigan State are playing each other in football, so this is perfect. There's a series of announcements. First, welcome to session 10887. This is a pro-con debate on the use of esophageal catheters in treating ARDS. Remember, all sessions can be evaluated through the mobile app and/or the online program. Please don't forget to evaluate this session course and the faculty when it is completed. The presenters are required to verbally disclose any